Bismillahirrahmanirrahim. Today we will discuss the vascular disorders of the intestine. The vascular disorders of the intestine are the disorders that are associated with the vascular supply to the intestine. And the two important conditions that we will discuss are the ischemic bowel disease and the hemorrhoids. By ischemia, we mean that when the blood supply to an organ is decreased, and if it is more severe, it will lead to infarction, which is the ischemic cell death that occurs in the tissue. We know that the intestines, they receive 25% of the blood of the cardiac output. We also know that the intestines have the very important functions of digestion, absorption, secretion, and propelling the food and feces towards the rectum for elimination from the body. So they have a lot of blood supply needed to perform their functions efficiently. We all have the experience of increased blood supply that occurs after meals. Anatomically, the greater portion of the gastrointestinal tract is supplied by the celiac trunk, which supplies the esophagus, stomach, and proximal duodenum. The most important superior mesenteric artery supplies the distal duodenum, jejunum, ileum, and the colon, ascending colon, and the transverse colon up to the splenic flexure. The inferior mesenteric artery supplies the descending colon, sigmoid colon, and rectum. The superior and inferior mesenteric arteries, they fan out to form branches. They branch and rebranch to form the mesenteric arcades. Interconnections between the arcades, as well as the collateral supply from the proximal celiac and distal pudendal and iliac circulations, are present to the intestine. And these interconnections and this dual blood supply make it possible for the bowel, small intestine, and the colon to tolerate the slowly progressive loss of blood supply from one artery. Because when the blood supply from one artery is decreased or reduced, the collateral circulation supply the blood and protects the intestine from ischemic and ischemic cell death. But in conditions where there is sudden occlusion of a major blood vessel and there is sudden compromise of the blood supply and perfusion, it may lead to infarction of the several meters of the intestine. The ischemia and infarction or loss of blood supply to the intestine is divided into the non-occlusive causes and occlusive causes. The occlusive causes include sudden loss of blood supply due to obstruction of a major vessel, and it will always cause the transmural infarction. By transmural, we mean that the whole thickness of the intestine is deprived of blood supply, and it will lead to ischemic necrotic cell death and can lead to serious complications. On the other hand, the non-occlusive type of ischemia, which is slowly progressive loss of blood supply, and that commonly occur in conditions in which there is systemic hypoperfusion, for example, shock shock hypovolemia and slowly and gradual loss of blood supply, which will lead to chronic hypoperfusion. So in these conditions, initially the mucosa is affected, and this is known as the mucosal infarction. As we know that the intestine is composed of mucosa, submucosa, muscular layer, and serosa. So in slowly progressive loss of blood supply, the mucosa is affected, which contains the epithelial lining, lamina propria, and muscularis mucosa. And this we know as the mucosal infarction. If the ischemia and infarction becomes more severe, it may cause mural infarction, in which the mucosa as well as the submucosa are also involved. While the occlusive type of ischemia or infarction, which is characterized by sudden obstruction of the blood supply from a major vessel, it will cause the infarction of the total length of the intestinal thickness, and this is known as the transmural infarction. The major causes of bowel ischemia, as I said, that they can be divided into occlusive and non-occlusive. The occlusive causes means obstruction of a major blood vessel, and this mostly results from severe atherosclerosis. We know that atherosclerosis is caused by the reactive oxygen species induced vascular injury, which is characterized and which is associated with the LDL cholesterol and give rise to the atherosclerotic plaques. The atherosclerotic plaques initiate thrombus formation, and there is thrombosis, which will cause obstruction. And if we talk about the bowel, it may cause obstruction of the mesenteric vessels. Sometimes a thrombus is embolized from thrombosis that occurs somewhere else in the body, and it may block the uh, mesenteric vessels. For example, embolization of a thrombus from cardiac vegetations, and sometimes present in the aortic atheromas. The aortic aneurysms and hypercoagulable states in which the uh, coagulability of the blood is increased, and certain diseases related to the blood vessels may also take part in the intestinal ischemia and infarction. Tumors, if they are present, can compress the blood vessels of the intestinal arteries and veins, and can lead to ischemia and infarction. And the same is true about the portal hypertension, in which the pressure in the portal circulation is increased. Trauma and abdominal masses, for example, carcinoma of the head of the pancreas, if it is present in the abdomen, it will compress the portal drainage and can lead to intestinal ischemia and infarction. The non-occlusive causes of intestinal ischemia and infarction, they result from generalized hypoperfusion. For example, in myocardial infarction, if there is sudden cardiac failure and the overall blood supply to the body is decreased, so as the other organs are affected from the hypoperfusion, the same is true about the intestine. The same type of non-occlusive uh, ischemia and infarction in the intestine may be associated with shock and dehydration or hypovolemia, in which the overall circulation to the body is affected. And sometimes certain drugs that have vasoconstrictive effects and they cause vasoconstriction of the blood vessels may also participate in intestinal ischemia and infarction. So we know that the transmural infarction, which involves the whole thickness of the intestine, is mostly caused by occlusive types of uh, causes that cause intestinal ischemia and infarction. And the major ones are the thrombosis in the mesenteric vessels, particularly the superior and inferior mesenteric arteries, and thromboembolization, in which a thrombus, for example, from cardiac vegetations is detached and embolized and block the intestinal vessels. And sometimes the physical compression by tumors, hernia, volvulus, and intussusception that commonly cause intestinal obstruction, and during the intestinal obstruction the intestinal vessels are compromised and can lead to ischemia or in severe cases infarction of the intestine. The occlusive type of causes mostly cause the infarction of the whole thickness of the intestinal wall, while in non-occlusive types of ischemia and infarctions, the mucosal and mural infarcts occur. In mucosal infarction, the mucosa, which contains the epithelial lining, lamina propria, and muscularis mucosa, they are affected. But if the non-occlusive infarction or ischemia becomes severe, it may cause mural infarcts in which the mucosa and submucosa both are affected. The non-occlusive types of ischemia and infarction mostly result from systemic hypoperfusion. For example, the hypovolemia or decreased blood volume that results from severe bleeding or hemorrhages, or dehydration, which may be caused by severe vomiting, diarrhea, and sometimes in acute myocardial infarctions, which leads to low cardiac output. The major determinants that will determine that how severe the ischemic bowel disease will be is the severity of the vascular compromise. For example, sudden occlusion of a major vessel, for example, the superior mesenteric artery, will have more severe effects than in non-occlusive types of ischemia, which is caused by hypoperfusion or generalized hypotension throughout the body. The time frame is very important because the long lasting ischemia will be having serious complications than the transient or slowly progressive occlusion. The type of the vessels also has important effects. For example, if the superior mesenteric artery is occluded, it will be having more serious complications because it supplies most of the small intestine and large intestine. Now, we know that when the cells are deprived of their oxygen supply or cellular hypoxia, which commonly results from ischemia, what happens that the cell will undergo ischemic cell death. The cell will pass from a reversible state of cell injury to irreversible injury in which cell death occurs. And in ischemic bowel disease, what happens that the necrotic cell death results in the formation of reactive oxygen species and various enzymes that are released from the dead and necrotic cells, and in the initial injury they will cause intestinal ischemia and infarction by the release of reactive oxygen species and various uh, enzymes released by the necrotic cell deaths. But in ischemic bowel disease, there are two sets of effects. The initial intestinal ischemia will cause mild to moderate damage, and most of the intestinal cells, they are cell live and can survive. But if the blood supply is re-established, here will occur the reperfusion injury, which is more severe because the initial injury will induce inflammation, and during the inflammatory process, the free radical productions and infiltration by the inflammatory cells that release inflammatory mediators and activation of the complement proteins and various cytokines, they will cause serious and severe injury in the second phase are the reperfusion injury. So the initial injury is not so severe, but it is the reperfusion injury which may cause severe and serious damage to the intestines. The anatomy of the intestine play important role in the ischemic bowel disease. We know that the intestinal crypts, they have glands in their lower portions where the stem cells are also present, and they are very important to generate new cells which are continually shed from the surface layers. So the cells that are located, the epithelial cells that are located at the tip of the villi, they are situated at the end of the capillary circulation, and they are more vulnerable and more susceptible to ischemic cell death as compared to the tips of the villi, which are comparatively well perfused. Additionally, there are two areas in the large intestine that are known as the watershed zones. By watershed zone, we mean that when a river is divided into two. So the first one is the splenic flexure, where the terminal branches of the superior and inferior mesenteric arteries perfuse the area. So in conditions of slowly progressive ischemia and infarction, in these areas they will receive blood from the alternate blood supply. But in conditions of sudden occlusion and sudden cessation of the blood supply, these areas are more severely affected as compared to the rest of the intestine. One watershed zone is at the splenic flexure, which is formed by the terminal, which is supplied by the terminal branches of the superior and inferior mesenteric arteries. The other one is located at the sigmoid colon and rectum, and here the inferior mesenteric arteries and hypogastric arteries have their terminal branches, and in conditions of severe occlusion, these two watershed zones are more susceptible to ischemia because they are supplied by the more distal and terminal branches of the arterial circulations. Now, morphologically, in mucosal infarction, there will be patchy mucosal hemorrhages in the mucosa, while the submucosa, muscular layer, and serosa, they are uh, comparatively normal. In mural infarction, the mucosa and submucosa and parts of the muscularis mucosa are also involved. While in transmural infarction, there will be hemorrhagic bowel segments, and there will also be associated uh, inflammation of the serosa and coagulative necrosis of the muscular layer. Death of the smooth muscle cells uh, can lead to perforation, and mostly perforation is seen in transmural infarctions in 1 to 4 days period. Microscopically, as I said, that the cells at the tip of the alveoli, they are more susceptible to ischemic cell death, so there will be atrophy and sloughing of the surface epithelium. But the crypts which are well perfused, they may be normal and sometimes hyperproliferative. The extent of inflammation and edema that is present in the intestine depends on the duration of the injury, and for example, if there is a superimposed bacterial infection which may cause pseudomembrane formation. In conditions where there is chronic vascular insufficiency, the elements of chronic inflammation, scarring, and fibrosis will be added, and fibrosis of the lamina propria may occur, and severe structure formation may result. The necrotic intestine grossly appears a dark red in appearance, and as compared to the viable portion of the intestine that is seen in the picture, which appears light pink. Under the microscope, we can see the mucosal erosions, and if the surface or the necrotic cell surface is sloughed off, it may result in the formation of ulcers. Below the area of erosion, mucosal erosion and ulceration, the area of hemorrhagic necrosis can be seen, which represents the area which is deprived of its blood supply. And more below the areas of the hemorrhagic necrosis, a zone of inflammation can be seen, which is characterized by the infiltration of the uh, inflammatory cells. In the acute phase, the neutrophils, and then in the chronic phase, the lymphocytes, plasma cells, and macrophages. The signs of symptoms of ischemic bowel disease, uh, initially there is pain, but at this stage, in the initial uh, stages of the disease, the abdomen may be soft and it may not be tender. When the bowel is deprived of its blood supply, it takes about 12 hours uh, for the infarction to develop, and it is characterized there will be by severe vomiting and sometimes bloody diarrhea. If hemorrhagic necrosis occurs in the areas of the intestine which is deprived of its blood supply. As the time goes on, the conditions become more severe and the abdomen becomes distended, and here develops the ileus where the bowel sounds goes away, and there is loss of intestinal peristalsis. In severe cases, bacterial infections may occur, and the patient may suffer from fever, hypotension, tachycardia, and uh, hypercapnia or increased breathing, which are compensatory mechanisms to compensate for the uh, uh, loss of perfusion. Sometimes, if perforation occurs or fluid accumulates at the abdomen, it will cause serious peritonitis with rebound tenderness and gourding, in which the abdominal wall muscles becomes tense. The diagnosis of the bowel ischemia and infarction is very crucial because it should be made as early as possible before the condition may lead to serious and lethal complications. The abdominal computed tomography, it will show bowel dilatation or dilation and the thickening of the bowel wall due to edema and inflammation, and sometimes air will be present in the intestinal wall, which is known as the intestinal pneumatosis. To visualize the blood flowing and the blood vessels, the computed tomography angiography uh, is helpful, and it may visualize blood flow in the bowel wall. And the routine laboratory tests, for example, there will be neutrophil leukocytosis and increase the WBC count and metabolic acidosis. Coming to the treatment of the bowel ischemia and infarction, uh, we have to replace the fluid loss by giving enough fluids, managing pain, and using antibiotics for treating the infections. But the definitive treatment of the intestinal infarction is surgical re-establishment of the blood. And sometimes, if it is appropriate, if we consider that there is some sort of thrombotic occlusion, we may use thrombolytic enzymes. If we suspect that there is a thrombotic clot or embolus present in the vessels of the intestines. In more serious cases in which gangrene of the intestine occur, the surgical resection of the infarcted bowel may be needed. So, summarizing what we said, that bowel ischemia and infarction occurs when the vessels are occluded by a blood clot, hernia, tumors, volvulus, or intussusception. All these causes cause acute intestinal obstruction and can lead to vascular compromise. Particularly For example, if a incarcerated hernia becomes strangulated, the blood vessels and vascular supply of the intestines are compromised. Bowel ischemia and infarction can also be caused by non-occlusive situations, for example, hypovolemia, hypotension, and the decreased perfusion that occur throughout the body, particularly after myocardial infarction, and hypovolemia that may occur due to severe fluid and blood loss, for example, due to hemorrhage, vomiting, severe diarrhea, and other causes. So whatsoever may be, if it is occlusive or non-occlusive, but if in untreated cases, it will cause severe damage and inflammation of the bowel. So the ischemic bowel disease can lead to various complications. For example, it depends on the severity of the illness and the time for which length of the time for which the intestine is deprived of its blood supply and the superimposed bacterial infection. And in severe cases, intestinal perforation and peritonitis may occur, and there may be systemic inflammatory response which may cause severe uh, loss of fluid and septic shock. The diagnosis of the intestinal ischemia and intestinal infarction is made by the CT scan, and the ultimate treatment is to re-establish the blood flow.